Okay, Misty, we're live if we want to go ahead and get started.
Thank you. Welcome, everybody, to the Home Health Quality Improvement Campaign's Underserved Population Network call. Thank you for taking time out of your day today to join us. We're very excited. I've been actually waiting for this session for months because we're going to be having the session entitled Advanced and Tips from Home Health Experts on 3 Key Topics. The handouts for today's session are posted on the HHQI website under the UP tab, so make sure you do download those. There are the PowerPoint handouts, and there should be also an additional handout posted there as well. All the phone lines are muted so that we are asking for all your Q&A or questions and comments to be posted in the chat box or the Q&A box. Today's session will be a little different because we are very fortunate to have 3 different speakers on 3 meaningful topics today. We're going to start with first asking a polling question. So look for the polling question to pop up onto your screen. And it's going to be, does your agency have a designated person to lead your PI or QI team? And then would you like to answer that? And then I'm going to be introducing the first speaker as we progress. And then we'll talk about the findings. The first speaker, the polling question should be coming. And in the meantime, I'm going to go ahead and introduce Cheryl Pacella. She is the owner of CAP Consulting. Cheryl is a graduate of Boston College and has earned her master's in community health and education from Salem State College. And she is currently a doctoral student at Regis College. She has over 20 years of experience as a home health clinical nurse specialist and a quality professional. She has worked with home health agencies on quality initiatives, and her areas of expertise include quality improvement, OASIS accuracy, Medicare billing, ICD-9 coding, care transitions, staff education, and survey preparation. And I've just been so fortunate to have known Cheryl. Several years ago, we at HHQI had worked with Cheryl in working on the Home Health campaign, and she helped us with a lot of materials on self-management when she worked at MassPro, which is the Massachusetts Quality Improvement Organization. In addition to her consulting at this time, she is an adjunct nursing faculty member at Mass Bay Community College, and I'd like to see where we are with our polling questions. We'll pull those down here in just a minute because we're just going to go ahead and start with Cheryl and let her present.
Hi, everyone. My name is Cheryl Pacella, and thank you so much for the introduction. I am so happy to be working with you folks today, and I have a lot of respect and admiration for the Home Health Quality Improvement Initiative. I had formerly worked with MassPro, and I had the opportunity to work with home care agencies throughout the state of Massachusetts. And I had been very happy to utilize the programs and all of the materials that were available to us through HHQI, including the best, performance improvement packages. But what I am going to talk to you today about is, will your PI program pass muster? And I'm going to ask if we could advance to the next slide, please. And here is my experience, my background. As I said, I have been in home health care for well over 23 years, and I'm very proud of the fact that I had the opportunity to work with MassPro and learn about what is available in terms of home health quality improvement. I'm going to pass on to the next slide, please. The challenge, first of all, it just is disheartening to me that there are so many of us And I am sure that it is not only in the state of Massachusetts, but perhaps throughout the country. There are so many people who have a strong foundation in quality improvement. And what is happening is many of us are retiring. We are leaving our positions, and we are moving on to that next stage in our life. And what is going to happen? Who is going to follow us? Many years ago, I had read this book, A Good Man is Hard to Find, by the author Flannery O'Connor. Well, guess what? So is trying to find a good QI person. These people are very difficult to find. And what is happening, I know in the state of Massachusetts, there are a number of positions that are vacant, and we are unable to fulfill these positions. And if you're not able to fulfill these positions, what do you need to do to make sure that all of the components of your QI program are being met successfully? And I'm looking at, does your agency have and I know that the question was in regards to a QI manager or director, and the good news is that 33 out of the respondents do agree that they do have someone in that capacity. And it looks like about, 17 or 11 out of 64 say they have someone available in a part-time basis. And then I know that a number of you, 27 out of 64, have not yet responded. But again, whether or not you have a formal person designated in this position, your agency needs to make sure that you are addressing all of the key components of a quality improvement, program within your organization. So as I said earlier, a lot of us are retiring, and we are perhaps a dying breed. So I'm going to ask if we can advance to the next slide, please. So what is the challenge? When we think about quality improvement, quality assurance, performance improvement, a lot of these terms are synonymous. Whatever you choose to call it, quality improvement has evolved over the years. The elements of the job description for a quality professional have also evolved. And no matter how big the agency is, someone within the organization is responsible for the oversight of providing quality, cost-effective care to our clients. I have included in today's session a handout, and the title of it is, Who is Currently Performing These Duties? So you will have an opportunity to bring this up and to review that to make sure that all of the components of this position are being addressed within the organization. Can I have the next slide, please? So these are the objectives. At the end of today's session, I'm hoping that you folks will be able to verbalize the key elements of a performance improvement program, identify the available resources that can provide guidance, and prioritize the tasks that must be accomplished not only quarterly but annually within the agency. Can I have the next slide, please? A number of agencies do not have a formal designated person as a QI manager / QI director. If you do not have anyone in that position, there's no excuse. There are still components of the position that need to be addressed. You need to identify tasks typically assigned to performance improvement. You need to compile and assess the data. For example, home health and care, the CASPA report, and our home health, consumer assessment of healthcare provider satisfaction. The acronym is HCAP. So if you do not have a QI manager, there needs to be someone within the agency who can compile this data. You need to delegate staff to cover each area. For example, chart audits, infection control, patient complaints, incident reports, compliance, denials. All of these areas must be addressed whether or not you have a QI manager. My recommendation is that there should be quarterly meetings within the agency at a minimum to address performance and concerns. So hopefully some of the information that is being compiled is being looked at by the agency at least on a quarterly basis. Can I have the next slide, please? DPHs do help, and what is happening is if you do not have a formally designated person within the agency, you need to make sure that certain components of quality improvement are being addressed. My recommendation is to make sure that you have a system in place in terms of conducting chart audits. You need to review the findings of the chart audits and then provide education to the clinical staff. I am currently working in the state of Massachusetts, and I can tell you that there are a number of home care agencies who have vacant positions for quality improvement, whether it's a manager or at a director level. I don't care if there are vacancies. There are certain things you have to do. And in terms of conducting chart audits, I always advise people you need to take a look at your average daily census. Whatever your average daily census is, you need to conduct a minimum of 10% chart audits per quarter. So if you have an agency with an average daily census of 200 patients, you need to review a minimum of 20 charts per quarter. If you are a large agency, for example, over 3,000 patients, that may not always be possible. So the expectation is 10% of your average daily census or a minimum of 30 chart reviews per quarter. You need to take a look at your policies and procedures, specifically in regards to OASIS correction and OASIS transmission. What I am finding is that when surveyors come on site, they are specifically looking at what is the agency's policy regarding OASIS transmission. Also take a look at infection control. You need to also think about preparation for staff. If I'm going to have a surveyor go out with a clinician, I need to make sure that that clinician, her car is meticulous, she has a designated clean area, a designated dirty area, and that she knows that the patient needs to be educated about the patient's rights and responsibilities. The patient needs to know that there is a hotline number that they can call if there is a specific complaint about the home care agency. So you need to educate home care agencies and clinicians about these things. And I can tell you that surveyors are all over sanitizing your hands and making sure that you're doing everything you can to prevent contamination and the spread of infection. So it's important to educate staff about these things. I can just share a funny anecdote with you. One of the home care agencies with whom I worked was going through the DPH survey, and what had happened was the survey process, the joint visit went extremely well. The surveyor was sitting in the car with the clinical nurse, and ironically, if you can believe it, the patient came out of her house, got in her car, and drove away. So there negates the homebound status. But that is a true story, but in any event, you have to stay on top of this. Now, as I said, I have a handout with my section of today's program. It talks specifically about the responsibilities of the QI manager and director. My recommendation is put together a binder and compile all of this information so that it will be available when the surveyor shows up at your door. And if you have any questions, I would be happy to address them later in the session. And I think at that point I can move on to my next slide, which is basically talking about this attachment to today's session. And I have included a lot of the references for today's program as well. And at this point, I'm going to advance the slide and I believe turn it over to our next presenter. But in the final slide, I have quotes that I would like to acknowledge. First of all, we are what we repeatedly do. Excellence is not an act, but a habit. If you do what you're supposed to do day by day, you don't need to worry about that unannounced survey. And finally, quality is free. It's not a gift, but it is free. What costs money, and we know this, are the unquality things, all the actions that involve not doing jobs right the first time. And we can see that in terms of what we're dealing with intense Medicare scrutiny and denial. So at this point, I'm going to turn it over. And as I said, I would be happy to address questions and answers. So I'm going to turn to the next slide, and I believe we're ready to move on to the next presenter.
Well, thank you so much, Cheryl. And for everyone, please, in the Q&A section, if you have questions for Cheryl, go ahead and type those in. We'll wait for a minute or so to address those with Cheryl. But if they come in and you think of something as we start forward, please put it in, and then we will come back at the very end and cover that as well. So just under the Q&A, feel free to type in your questions as we go along. And currently, make sure that you see that if you have not downloaded the handouts, they are on our HHQI website under the Up in Event Archives is where they are posted, or that's where the recording will be posted tomorrow. The handouts are currently on the current Up page. And afterwards, you'll receive an email as well about the presentation. So I'll just make sure everybody saw that messages. Oh, great. We have our first question from Florence. Thank you. What are we required to track and monitor in infection control? Cheryl?
Yes, I'm happy to address that. In terms of infection control, I would highly recommend that you track, for example, infections that are pertaining to surgical site infections. I know that the hospitals are looking at this as well, and also in terms of urinary tract infections. So I would suggest that you begin to compile data if you have not already done so, specifically in regards to those two items, urinary tract infections and surgical site infections. I'm not sure if CMS or Medicare makes a distinction in terms of what we have to report, but those are the two areas that I would definitely hone in on.
Thank you, Cheryl. And just as thank you again, Florence, for a great question. And if you need just a nice, simple one-page teaching sheet on surgical infections, you can look in the immunization and infection prevention. There are 4 different single pages related to, I think there's MRSA, there is C. diff, but I do know that there is a surgical infection one-page sheet that's great for education or brushing up for clinicians as well. Any additional questions at this time? We'll hold until the end, but do keep putting your questions in, please. And Florence, thank you very much, Cheryl. Misty Dyke, would you please go ahead and put up the next polling question? This is going to be for all of you to answer, just to give us some feedback, gets us ready to change our topic. And while you're answering the question on how ready you feel if the surveyor walked in your door right now, I'm going to introduce our next speaker, and that is Nancy Allen. She's the founder of Solutions for Care, Inc. It is a consulting and care management company specializing in training, seminars, and all aspects of home care. She has over 30 years of experience in clinician, provider, state, and accreditation survey. Nancy serves as an accreditation surveyor with the Accreditation Commission for Healthcare and is a certified CHAP consultant. Her qualifications and experiences include certification as a clinical specialist in home health with the American Nurses Credentialing Center and qualifications by the Center for Medicare and Medicaid Services as a state surveyor. She is a Medicare hearing officer for the Medicare Fair Hearings Department of CMS. She is certified as a case manager by the National Academy of Certified Care Managers. In addition, she is also an author and a reviewer for the Home Health Care Nurse, the Journal for Home Health and Care and Not Hospice. She is on the editorial board for the Journal of Community Health Nursing and Home Health Aid Digest. Her book, Survivor, 10 Practical Steps to Survey Survival, includes recent survey changes and interviews with government and accreditation surveyors who reveal their secrets to a successful survey. It's considered to be a very fun and easy read and has helped many to not only survive survey, but to eliminate deficiencies and improve patient care. And we see that from our polling results that actually 46% of you are feeling pretty good. I think that's outstanding. 11% feel very confident. That's totally awesome. Now, 34% of you feel just okay, and some of you still aren't feeling quite as comfortable. So we're hoping that you'll learn a lot from Nancy. So we are going to turn the ball over to Nancy and allow her to present.
Okay, thank you very much. We're going to move on to the next slide. Do I have the control here?
You. I'll move it to the first one, and then I guess you did move it yourself. Then you just move the slide to the top. Thank you, Nancy.
All right. Awesome. Well, I come from the background of being a state surveyor. I'm now an accreditation surveyor. I have a consulting company, but I've also been that provider who has been on the other side of the fence of being surveyed, and it's always nerve-wracking. It's always like taking a test. So we're going to talk about some tips of going through a survey. And our objective for this session is that you'll always be prepared for survey. And then methods to expedite the survey. You want that surveyor in, you want them out as quickly as possible. And you know what? They want that too. And we're going to talk about how to avoid the common mistakes. Some of my funniest experiences have been when I walk into the door of an agency and I say, I'm here to do their survey. And many look like that deer in the headlights. So who did you say you were? One of my funniest experiences, I walked in and I said to the receptionist that I was here to do the survey. She didn't talk to me at all, bolted out of her seat like a town crier, all the way down the hall going, the surveyor's here, the surveyor's here. So, you know, when you're standing there and you're going, what do I do next, when there's nobody there to talk to, it leaves the surveyor befuddled as well. So you want to make sure that you're ready for survey. All surveys are unannounced unless it's an initial survey. So prepare your staff. This is a part of doing business. Educate your staff. Dispel the myth that the surveyor is out to get you, they're trying to trick you, or they're trying to trip you up. I actually heard at a state conference, one of the speakers actually said, well, you know those surveyors, they're always trying to trip you and trip you up. Well, that's just not so. So educate your staff and dispel those myths. Everyone gets nervous, and that is okay. The surveyor understands that you're nervous and your mind goes blank. That is not a problem. It is important that you give your staff the knowledge to go through a survey with confidence, because knowledge is power. What kind of knowledge do we need? You must be familiar with the Medicare and state regulations, depending on whether you're a licensed or a Medicare certified agency. If you're accredited, you must know the standards. That is your test. That is what you're going to be tested on. Don't just guess about the meaning of regulations and standards. Read interpretive guidelines in the regulations. When you download or print off for your agency, you want the set of regulations that it states for surveyors. okay, because then you'll know exactly what they are looking for. On accreditation standards, it has interpretive guidelines. In those interpretive guidelines, it will tell you what that surveyor is going to look for. Read the original law if there's some kind of question, because all the regulations are based on the law, and use a knowledgeable consultant if needed. Any deficiency that is cited is related to or cited from the regulation and not the interpretive guidelines. Don't just guess about meaning. Respectfully ask questions of the surveyor if you don't know what they're talking about. Listen to instructions carefully. Have a notebook handy. Write down those questions. Make the home health agency response match exactly what is being asked. If they're asking about your orientation program, you don't have to start talking about your PI and all the hard time you've had about the staff. Just answer the question just like you would for a lawyer. What is that surveyor thinking? What is the anatomy of a surveyor? Their head is filled with federal and state regulation and accreditation standards, either folding in their briefcase or in their laptop or software, whatever they have here. But you know what? They're not trying to trip you up. They have too much work to do. Listen carefully to what they're saying. Study the regulations and standards. As you said, this is your test. Answer what is only what is being asked. If you're asked something and you do not know, respond that I will find that out for you. Most of the time, they're asking you a question that you should know. Expedite your survey with the following strategies. Have a survey notebook or a binder and have the items ready all the time. In a survey, you'll always be asked for your census. You'll be asked for your unduplicated admissions and discharges. These are things that are asked over and over again. Have these items ready and be prepared to present to a surveyor so they can start a survey as soon as they walk through your door. Escort that surveyor to a pre-planned area in your office, wherever that might be. Know what to expect. There are 6 common components of any survey. It doesn't matter if it's a complaint or licensure or Medicare, it is always the same. There's pre-survey tasks where the surveyor has to gather information about you from previous surveys and complaints, etc. And then there's the entrance conference. This sets the tone, and you should go into that conference with confidence. Identify the key people, the liaison between the surveyor and the staff, and the organizational chart should match those key positions. If you're telling them something totally different than what's on that org chart, that's a problem. The surveyor will tell you the purpose, the length, and the structure of the survey. If they don't tell you what kind of survey it is, make sure you ask. Okay, any other information? They'll tell you at that time. The home visit schedule is the most complicated and usually the longest. It is really hard sometimes getting the patient and the staff and the surveyor's time, etc., all coordinated. Start on that almost immediately. The surveyor's time is limited. There's multiple tasks to complete. So often the tasks have to be arranged around those home visits, and you don't want to have the surveyor see a patient at 7 and then 11 and try to create it in blocks of time. So think about home visits before you ever have a survey. Information gathering. This is where all the information from the patient charts, personnel charts, the home visits, human resources, observation of the office, the systems of PI, et cetera, are being looked at. And then there's going to be analysis of all that information that has been gathered. Are there trends of noncompliance? Are there systems in place to ensure compliance? Did the home health agency identify any of the deficiencies that the surveyor is finding? And if so, what did the agency do about it? Last is the exit conference or interview. Hopefully, the surveyor will, at the end of each day, give you some kind of summary of that day's event. They will ask you for things that they cannot find, and you have the opportunity to provide that information before the final exit, and it is important that you do so. It's time for the surveyor to ask any questions, and then you can provide that information. Try to do that before the last day, because you don't want to be cited if you don't have to be. Staff were informed on the final exit conference of observations and findings that the surveyor has discovered. You can, again, ask questions to gain clarification. If you don't understand what they're saying, make sure you ask in a respectful way. Deficiencies and procedures are described that are non-compliant with specific regulations and standards. And then task 6 is your statement of deficiencies. This is a written statement of the survey findings, and it'll be sent shortly after the survey. If there are deficiencies, a plan of correction will need to be written by the agency and submitted within the requested time frame by the surveying organization. And then lastly, see the survey process as a learning event and help your staff to see it that way. The regulations and standards are in place to protect patients, ensure efficient operations of a home health agency. It also provides checks and balances to ensure compliance and delivery of quality of care. Try to avoid disconnects between the survey and what you're actually doing in your day-to-day operations. Integrate those survey processes. And what I mean by that, your audits, the things you're doing, everything that is required during a survey should be part of your day-to-day operation. And once again, make that survey a learning experience. I just want to mention my book. It's a fun, easy read. It gives 10 hard-hitting practical tips for going through a survey with ease. And I'm always really gratified when people come up and say, hey, we had our first deficiency-free survey. Because it just gives them tips from being a provider and being a survey and being on both sides of the fence. And I've also included tips from the surveyors, such as never throw things at the surveyor. And if you kill the surveyor while you're driving, you probably won't pass your survey.
Wonderful. Okay, if you have questions, I think Nancy's presentation was jam-packed with a lot of key information. I think the biggest tip that I got immediately, Nancy, and I have never made part of my project plan in prepping for a survey, is to educate the receptionist, and that is so true. I have seen that happen, or the panic. So it is all of the staff, but I think with education and prep, you ease so much tension. The other key piece that I heard is keeping your records up to date and keeping everything organized. And I think some of the same common tips that we may also hear from Barbara, but we already heard from Cheryl, is to be organized, to be prepared, and to have a binder. I heard that from both speakers so far, that the more organized you are with your record keeping and having everything ready and prepared constantly, it doesn't matter what day the surveyor comes in.
That's right.
So if you have questions, please go ahead and type those in. You have Nancy at your service to answer Survivor. Of course, this is a fitting day. It's Wednesday, and Survivor's on tonight, too. Any questions related to surveys? And we'll allow some questions to continue to filter in. We're going to go ahead, and we'll see who might start it, but I'm going to go ahead and turn over to introducing Barbara. But Misty Dyke, would you go ahead and put up our third polling question for us? And this will be about ADRs. So answer that question while I introduce our very next speaker. Barbara Piscor is the owner of BKT Healthcare Resources. It's a consulting organization for home health, hospice, and private duty agencies. Her focus areas are operational analysis, new business startups, regulatory compliance, survey preparation, and quality improvement. Barbara's past experiences include clinical nursing and healthcare administration, with a progressive experience in day-to-day operations at senior management level in home health, hospice, and private duty. She has been a surveyor for the Joint Commission for 10 years. Barbara is a registered nurse with a master's preparation in public health and postgraduate courses in accounting, financial management, and the third-party reimbursement. She is board certified by ANCC as an advanced nurse executive. So go ahead and answer your polling question, and then we'll ask Misty to go ahead and post those results for us to see if you're seeing an increase in your ADRs in your area. And while we're finishing that up, I'm going to go ahead and let's just turn it over to Barbara. Go right ahead, Barbara.
Good afternoon, everyone. Misty's absolutely correct.
I'm going to talk about pulling together a binder also. Okay, so all of us are thinking in that same direction. And my topic is the additional development requests. Most of us refer to them as additional documentation requests, those ADRs. Now, some of you who are newer agencies might be thinking, well, gee, I've never gotten an ADR. While others of you might be saying, oh, no, not another ADR, when you see that you need to respond to one. However, if you have that pattern and you're prepared for checking for ADRs, responding to ADRs, tracking them, and then appealing them if you need to, you'll be on top of the process. Move to the map. If you're not familiar with your Medicare Administrative Contractor, your MAC, they should become your new best friend. The MACs are assigned pretty much geographically. There are a few exceptions to that, but you see New England has one, National Heritage Insurance. The middle of the country, as well as Mid-Atlantic, it's Cigna, referred to as CGS, then Palmetto, mostly in the south, not even coming up into the Great Lakes area, and then on the west, National Government Services, or NGS. Your MACs are subcontractors for CMS, and they handle your billing, audits of all types, as well as medical review. And the next slide. For understanding medical review, if you can get on top of the syncing process, you'll really be better off. Now, lots of us get pretty paranoid, and we think, oh, no, what did I do wrong? ADR-wise, why are they out? Why are they looking at us? Well, believe it or not, some of them are really random. You just hit the lottery that day, and you have a random ADR. And if you're a newer agency, you really should be thankful for it almost, because you can learn a lot by having an ADR and seeing what the response is. You can get enough reinforcement that, yeah, your system's working. There's a widespread edit system that are much more targeted. Currently, home health agencies are having a widespread edit on face-to-face encounters, and that's our current bane of our existence in home health at the moment. Also, therapy utilization, if it's fairly high, you might get identified for a widespread audit in that area. The third episode of essential hypertension as a primary diagnosis might hit the lottery for you. A relatively new widespread audit is a beneficiary-specific edit, and that is, say, a home health agency has had an ADR on a particular patient who they then discharge if it's denied, okay, and then that patient moves on to another agency. That new agency will get an ADR very quickly. Likewise, if a hospice agency has had an ADR and then had a claim denied, and the patient ends up by then being what's called a live discharge in the hospice world, and then that patient is picked up by a home health agency, they will probably get an ADR automatically with the first claim. So there's that kind of thinking. There's also provider-specific edits, and that's really where you have a trend, perhaps denials based on widespread edits, has identified some issues. Most of the ADRs are done in a post-payment situation, so that you've already gotten payment, and that now you have an ADR, and if payment is denied, they take that money back.
Sometimes provider-specific edits, where the provider does get under a focused medical review, will convert to prepayment so that no money is paid on any claim if there, unless documentation is sent in. That gets pretty serious from the cash flow perspective. Next slide is my binder. It was the best clip art I could find on it. But it really is organizing your information. And I would just reinforce some of the PI items that Cheryl noted in terms of just good record reviews. Some of it's that orientation and training, OASIS accuracy on the home health side, clinical eligibility for hospice on that hospice side, but the quarterly clinical record reviews, having a tight new admission review system, whether it's home health or hospice, as well as having a pre-bill audit system, is really what will pick up your problems so that when you do get an ADR, you're well prepared for it. The next slide related to checking for ADRs. You will not get a hard copy in the mail request. It all comes through the FISC system and the common working file. So if any of you are managers on this call today and you don't know who in your agency checks for ADRs right after the webinar, I'd encourage you to run around and find out who does this. Make sure that someone, it's usually billing, whoever handles the billing piece of things, they should be checking that common working file at least on a weekly basis, and frankly, I recommend more often, but at least on that weekly routine basis. You want to be upfront and right away when it is identified, you want to assign responsibility for carrying through the response. Now, I would say that should have already been in with your preparation, but if it hasn't been done, you do it then. After you calm down, read the instructions that accompany that ADR request, because initially it will look like a hieroglyphic. However, look at it carefully. It will tell you what claim is being targeted, what to send, and where to send it to. And these are all crucial pieces of information. You can't just send it to a generic address for your MAC. There are specific addresses, specific post boxes usually that handle it. To respond to the ADR, which is next slide, you want to review all your documentation in detail, not unlike what you would be doing oftentimes for that quarterly clinical record review. But the reason you want to review all of that is you want to begin to develop where do you need support. And I strongly recommend that you do a cover letter when you're responding. Now, that's not required, but you can get in front of where you may identify some weaknesses related to the documentation. Make the medical reviewer's job easier. They're, for the most part, they're all RNs with home health or hospice experience who are reviewing, but they've got a ton of work. And you want to make that surveyor's job easier so that she gets in and out the door fast. You want that medical reviewer to also be able to roll through that record, and your cover letter can help. However, some hints. Don't highlight your actual documentation, like with a yellow highlighter, and don't staple things together. That slows down their process, as well as they'll be scanning your paper items that you send in, and the highlighting will obliterate some of the information. But in that cover letter, if you look and you find that homebound isn't supported very well, especially if you have just drop-downs related to homebound status, and every one of your patients it says dyspnea on exertion and nothing more, you want to review that documentation to be able to lead the Medicare reviewer to where you say that, page 9 demonstrates that they're a fall risk and they were rated at this point. The PT evaluation on page such and such demonstrates or reflects that they have coordination problems, they have balance problems. You can send any additional supportive material, an H&P, a discharge summary, say, from the hospital, a lab report, anything that will help your case is good. You do want to weigh it to make sure that it doesn't bring any other issues up. But where you see that it's helpful, you want to do that. Observe the time deadline. You have 30 days to send your material in. Automatically on the 46th day, if there's no response, the claim or the ADR will go to an unpaid situation. There's a medical hierarchy. Home health will look at items in this step, that slide that says medical review hierarchy for home health. If they find that the face-to-face encounter, for example, does not adequately support the need for home health, they'll stop right there and won't even look at the remainder. You'll have a time to respond to a technical denial, and eventually there may be problems in other areas, but they stop at the first item that it gives them a denial to. The same thing for hospice in the next slide. If there's not a valid benefit election, they stop and then go on. Then they'll look at that face-to-face encounter for the third benefit period review, for the certification for terminal illness. So it's the same kind of a thinking process there. After you put things in the mail, then there are mailing as well as electronic submission options. But either way, you want to maintain a very strict log for yourself in terms of your time deadlines, your mailing dates, your certification that they received things, all of your contact information. It especially becomes important if you go into the appeal process. You'll want to have that log even for your ADR outcomes. And those outcomes, you want to track your denial reasons, and if, for those denials, then build them into a performance improvement plan. Because once you get a denial, you may begin to see a little uptick in the number of ADRs that you get. You want to get on top of that as an issue. You can get that technical denial. You can have it paid in full. Isn't that nice news? It can be partial denial. Say, for example, if your therapy reassessment visits haven't been on track, that can lead to a partial, or it can be fully denied. Palmetto is saying that 1/2 of their denials now are due to face-to-face encounters in home health, and 21% because agencies don't respond. They maybe didn't have a good checking system. If you need to move into the appeal process, there's time sensitivity at each of those levels on that slide identified as appealing. You need to look at what forms need to be used. It changes at each level. There are different time requirements. The appeal process is a long, painful process. So the more upfront preparation and the hopes for a fully paid ADR help you out. Lots of agencies will be successful in their appeals, but it's a long, expensive process for you as an agency. The remaining slides are just helpful websites. As you have time, go onto your MAC's website and cruise around, because most of them have very good educational resources in relation to ADRs and the appeal process. Then, of course, your benefit manual, your claims processing manual, MLN and transmittals are extremely helpful too. We're ready for questions.
We already have one because Ingrid was chopping at the bit for you, Barbara. She has a question that says, how do you find out what the exact reason is for the denial? For example, a face-to-face documentation incompletion. She has in parentheses, it has been timely completed, etc. So she's unsure exactly what they're looking for.
Okay, well, they're probably in that situation. If you have a signed, dated, and timely completed one, it's probably because there was not good clinical support for the reason for home health services, or the homebound was not supported. Because just simply having that paper with those minimal requirements doesn't pass muster. For example, I see denials every day because the physician simply responded with a diagnosis. And I can tell a little story. I was at a meeting a few days ago, and an agency director brought in and shared with me, had a face-to-face encounter that in the clinical support section, the physician said, and actually wrote this, I mean, this was a serious document, that because I say so, and under homebound, he wrote, he or she, I don't know which it was, wrote, because she is. And that was the full face-to-face encounter. It had a good day, had a signature, but there are some vagaries and subjectivities with some of the MACs. Some of them are getting a little harder. We're learning what they accept and what they don't. But remember, you can challenge it. I would take most every face-to-face encounter denial, I'd take it to the next level, and at least for the reconsideration and to redetermination. I'd take it all the way through for every face-to-face. But you may have to hunt through your record as well as add some additional documentation. But for the most part, what needs to be done is just more education with physicians. And I say that almost apologetically because I know how hard it is.
Great points, Barbara. We have 2 more questions already in the queue. So the next question is from Joan. If the ADR is not denied, if the ADR is not denied, will you be notified of this?
Okay, no, you need to track it. That's another piece of the tracking. If it's not denied, you'll eventually see it on your remittance advice that they didn't take back any money. But you need to keep going into the common working file, and it does permit you then, the status code will change from the code that says it's in ADR process to a payment code.
And that can take,
go ahead. Track it. Go ahead.
And that can take a long period of time, so it is important for your tracking log to make sure that you constantly take a look for that, correct?
The MAC has 60 days to handle it. That's what CMS has them on that time clock. Throughout that period, if it's a quick review, it can be earlier than that, and you'll know the status.
Right. And then also a question from Tina. What is the definition of LCDs on your slide?
Okay, those are local coverage determinations. And on the home health side, there really is only one firm one, and that has to do with therapy. You will find your LCD, and it's unique to each MAC on their website. On the hospice side, of course, they've got diagnosis-specific LCDs as well as diagnostic as well as functional LCDs. And, for example, on the hospice side, it will say for end-stage cardiac diagnosis that they require a particular New York Heart Association status for them. It's very specific. But there's not a lot of LCDs help on the home health side.
Right. Great. Thank you for the questions, everyone. They were excellent. We are going to move on to a couple announcements, and we'll come back in one moment about the speakers again. The next up networking webinars, because we're going into the holiday seasons, we are going to resume them in February. We'll have 2 a month. It's always the second and the the second and the fourth Wednesday of each month, because we know you're very, very busy through the holidays. So watch for some updates and notices. Do look for, or you probably have already received, many of you on the call for agencies, that we do a BPIP assessment, and this one is on the immunization and infection prevention. BPIP, it was sent out around the 5th. Somebody at your organization received it. It takes less than 5 minutes to complete. It gives us extremely valuable information, so we'd appreciate the feedback. Our next live chat is where if there's no audio, you just type in your answers, like in the chat box with your questions, and we answer questions on what topics or resources that you're looking for. We have that actually this Friday from 2 to 3 Eastern Time. It is a 1-hour session. You can register for a reminder by going onto the link that is provided, or going under, I believe, networking will provide, yes, networking and under live chat. And we want to thank you, all of our speakers. I think this was an extremely wonderful panel of speakers. And just look at the amount of expertise that they each brought to the plate through their bios, plus all the great information that they provided. So I hope that you can take the pieces and information that they have provided you into your day-to-day practices, so that you will make sure that you have a great PI program, no matter your size, no matter the activities that you're doing. Also to be prepared for your surveyors, as well as getting ADR notices, that you're able to competently find the information, track the information, and continue to follow up with that. And continue to learn from all of those experiences. I think that was a common message, as well as being organized and having a binder was common messages from our speakers today. So with that, we are to the top of the hour, so I thank you all very much. I hope everyone has a wonderful holiday. You will receive an evaluation of this call if you would complete that and provide us some feedback on today's call. And remember to get the handouts that are posted on HHQI under the Up tab. So once again, thank you all very much, including our great speakers.
Thank you. Thank you.